Let's talk about the Carfilzomib trial that Harry alluded to earlier that shows overall survival advantage. There was a doublet regimen with higher doses of Carfilzomib called the Endeavour trial. I think, Bob, you might have been involved with that. That also showed an advantage to that versus Bortezomib. Is anybody using Carfilzomib with dexamethasone alone at relapse, or is this a triplet crowd here? Anybody?
Probably a triplet crowd,
Yeah.
I would guess.
Triplets.
Or at
Part of the
least-
reason why I think we're using triplets is we're starting out by using triplets at the beginning. And if you think about relapse, they're becoming more genetically complex. So then going back to a doublet is almost going backwards, I think, except if there is a toxicity issue. Of course, we will use a doublet in that
What
situation.
about a non-IMiD containing regimen? So there was an abstract here from the United Kingdom which looked at cyclophosphamide with Carfilzomib with, I thought, really quite impressive results. I don't know if anybody's had a chance to review that in any detail. Does anybody use that regimen at relapse? Bob, I'll pick on you again.
Yeah, I think alkylating agents are certainly reasonable to use at the time of relapse. Cyclophosphamide is a good partner. We've also done bendamustine with Carfilzomib, and it works quite well. I think the major concern, of course, is that you can't keep people on it for too long because you run into myelosuppression, and then you may compromise what they can do next, because if they continue to have marrow suppression, their counts are not good enough for clinical trials.
I guess I'm a bit of a fan of Carfilzomib with cyclophosphamide, particularly when you've been on lenalidomide and you're progressing. Sometimes the notion of going to a second immune modulator versus switching therapy completely doesn't sit well with me. Anybody?
I tend to use Carfilzomib, Cytoxan, Dex quite a lot, specifically in those extramedullary aggressive kind of patients. It works quite well.
Now, we haven't addressed toxicity of any of the drugs so far. Let's talk about Carfilzomib since we're on that topic. What's your latest thinking on the tolerability of Carfilzomib, Harry?
I find it actually extremely well tolerated, providing you pick the right patient and the right dose. So we talked about that variety of KRD regimens and KCD regimens and K dose. So the 2027 dose is generally well tolerated. And once you go up to 36 milligrams, which is the dose that's being tested in the ECOG trial that Noopur alluded to, with IMiDs, that again is better, relatively well tolerated by newly diagnosed patients. But once you go up to the 56 and the 70s, then the tolerability becomes an issue. And I find a lot of endothelial toxicity, such as hypertension, atrial fibrillation, and picking the right patient is the most important thing, in my opinion, in practice for the practicing oncologist. For an elderly patient, I would always start at the lower dose and titrate it up as required and be very quick to reduce dose if measuring their blood pressures when they show up for treatment is one of the
this is a very important practice point. We need to do a better job managing hypertension. Right. Noopur, your experience with
So, we have gone to using weekly doses of Carfilzomib. We do go up to 56 mg per meter square on a weekly schedule. But I agree with you, Hari, especially in the upfront setting, or if you have relapse with high disease burden, that's where you end up seeing more endothelial toxicity. So when you starting off with a lower dose, but we are generally able to build up to that dose of a higher dose of weekly.
I want to be clear for the audience, when you're talking about endothelial toxicity, what are you referring to?
So we've seen a lot of blood, you can get blood clots, PEs, as was seen also in the KRD DARA study, which has been presented at ASCO. They saw quite a few PEs there. So in a newly diagnosed patient where you have a high disease burden, you can actually see these kinds of toxicities.
Thoughts on, let's just stick with Kyprolis for a minute, Carfilzomib. Bob, what's your experience like with that?
Well, beyond the blood pressure issues and endothelial issues that were mentioned, people can have shortness of breath / dyspnea. So that's the other one, which you can see in probably around 10%. And as long as you don't give them too much fluid, because in the early days of Carfilzomib, there was a notion that maybe there was tumor lysis and you needed to pre and post hydrate them. But if you get away from that, it's much less of an issue. And there may be a benefit to giving the higher dose once per week based on some randomized data that so far have been announced only in a press release, but that we hope to be able to see soon.
You're referring to the Arrow clinical trial?
Correct.
Yeah, so what do you think about that? The press release demonstrates that weekly has a slightly better progression-free survival than, and I think it was 11 months versus 8 or something for the weekly versus bi-weekly single-agent carfilzomib with dexamethasone. How do you react to that? Are you going to switch to weekly dosing? Wait for the data? What's your plan?
I would definitely like to see the data. I think that, of course, in older patients, as was discussed earlier, the higher dose could be a little bit problematic.
And by high, what do you mean? 70
Well,
milligrams?
even 50 and north of that, but certainly 70-ish, which is what was used here. But I do think the convenience factor is there, and it may make it easier to combine that with other drugs for new 3-drug regimens.
My guess is the Arrow clinical trial we're talking about was a phase 3 trial of bi-weekly carfilzomib at 27 milligrams per meter squared versus once weekly at 70. I think to me the main take home will be that it provides a justification for moving to weekly for the convenience factor. Yeah. Cristina, do you use weekly or twice weekly?
Yes, but I've not been able to go up to the 70, and we were talking about using carfilzomib with the dexamethasone versus the triplet. When you use that, I think going up with the dose is even more important. I think in the triplet we see that we have to settle down with a lower dose for toxicity. But yeah, I think like Noopur, I think the 56 is becoming my threshold for the weekly.
Mm-hmm. I want to just close this session with a couple of words on daratumumab management and toxicity, and maybe get Noopur your advice to the audience on using daratumumab.
So it's usually most of the toxicities, infusion-related toxicities that you see with daratumumab, and it's the first 1 and 2 infusions. We're doing a pretty good job with the pre-medications now. We use routinely montelukast, etc., and we're not seeing as many. But you know, these are manageable toxicities. The first dose is a long dose, and as Bob has already pointed out, at this meeting you're going to hear about the subcutaneous version, and the subcutaneous version soon to be had is going to be given over like 5 to 10 minutes actually. So that's going to change this completely.